Hello everyone, welcome back to this series of lectures in nephrology. This is Dr. Maitreyi. Today we'll be discussing about chronic kidney disease. Okay, so let's begin. So let us look at the definition of chronic kidney disease. So CKD is basically defined as an abnormality in the kidney structure or function which is present for more than 3 months. Right? So any abnormality in the kidney structure or function which is present for more than 3 months is what we call as CKD. Alright? Fine. Now let us understand the causes of CKD. There are 4 major important causes of CKD which you should be aware of and which are the most common causes of CKD reported worldwide. So the first and the most important cause is your diabetic nephropathy. Right? So we know that India is the diabetes capital of the world. So diabetic nephropathy is one of the most important causes for CKD worldwide. Right? So we know that CKD is characterized by a progressive decline in the GFR. So what is the rate of GFR decline in diabetic nephropathy? It is around 8 to 10 ml per year. So with age, there is a progressive decline in GFR as well, but that is only about 0.8 ml per year. That is only about 0.8 ml per year. So you can see that diabetic nephropathy is one of the worst diseases to have because the highest rate of GFR decline is with diabetic nephropathy. Followed by which we have chronic glomerulonephritis, which we call SCGN, which has a rate of about 6 to 8, and ischemic nephropathy at around 4 to 6, and chronic tubulointerstitial disease, which has a GFR decline of around 2 to 4 ml per year. Apart from that, certain miscellaneous causes like polycystic kidney disease can also be associated with chronic kidney disease. So this is about your broad etiologies for chronic kidney disease. So what is chronic kidney disease? It is basically defined as any abnormality in kidney structure or function which is present for more than 3 months. And what are the broad etiologies of CKD? We have already looked at. Now let us understand the risk factors for chronic kidney disease. So what are the risk factors for CKD? So any non-renal chronic systemic disease by itself is a risk factor. For example, many comorbidities like hypertension, diabetes, obesity, right? So hypertension, diabetes, obesity, chronic maybe heart failure or atherosclerosis, all of these are risk factors for renal disease as well. Now, infections, right? So a lot of infections are associated with chronic kidney disease. We have heard of HIV associated nephropathy or HIVAN, and in the recent times with COVID, there have been many reports of COVID associated nephropathy which is called as COVAN. Okay. Apart from this, all of these viral infections, if they are chronic, like even hepatitis B or C, they result in a pro-inflammatory state which can result in CKD as well. Fine. Then aging, then sex. As per the gender, males usually have a more predisposition towards chronic kidney disease. Then lifestyle, right? Smoking, alcohol, or even a sedentary lifestyle is associated with an increased risk of CKD. Then certain other genetic features including the presence of a premature birth or a low for gestational age baby. Why? Because the GFR of the kidney is given by the number of nephrons into single nephron GFR. Right? So if the number of nephrons itself are low, because your number of nephrons is determined at birth, right? So the number of nephrons that you have is determined at birth. So any premature baby or a small for gestational age baby can be associated with a lower GFR and increased risk of chronic kidney disease. Alright, so this is associated with an increased risk of chronic kidney disease. So let us understand the pathophysiology of chronic kidney disease. So what happens exactly in CKD? Okay, so we understood that CKD basically occurs due to progressive decline in GFR, and GFR is dependent upon the number of nephrons. So whenever there is a nephron loss, so because of some insult to the kidney, there is a nephron loss. So whenever there is a nephron loss, there is intraglomerular hypertension. Okay, so whenever there is a nephron loss, there is intraglomerular hypertension. The other glomeruli try to compensate. Okay, so once the other glomeruli try to compensate, what happens is that there can be mesangial expansion. There can be mesangial expansion. We know that the glomerulus is contained within the Bowman space and there is some mesangium there. So there can be mesangium expansion and there can be glomerulosclerosis. Right? There can be glomerulosclerosis. That means initially the hyperfiltration of the remaining GFR helps in maintaining the GFR. But over time, whenever there is mesangial expansion, what happens is that there is excessive secretion of proteins. So can you see in this glomerulus, right? So this is the afferent arteriole, this is the efferent arteriole. Okay, so initially hyperfiltration makes sure that the afferent arteriole is dilated, efferent arteriole is constricted and GFR is maintained. But as the insult progresses, there will be excessive leak of proteins. This is nothing but your tubules, right? So there is excessive leak of proteins. And over time, can you see that the proteins are leaking into the Bowman space as well? And there can be scarring. There can be scarring. This is nothing but your scarring. This is what we call as glomerulosclerosis. Okay, so there can be scarring of the nephrons because of this when they try to compensate for this glomerular hypertrophy and this protein leak. Now, why does this protein leak happen? This happens because of effacement of podocytes. So this is your glomerulus and each glomerulus has these cells which are called as podocytes. So the podocytes basically help in keeping the filtration barrier intact. They do not allow the proteins to pass through. We will be understanding the structure of the filtration barrier in detail in our discussion of glomerulonephritis and nephrotic syndrome. So these podocytes generally help in keeping the filtration barrier and they do not allow proteins to pass through in the normal urine. Okay, so there will be effacement of the podocytes. Can you see here the podocytes are broken down. When the podocytes are broken down, the proteins begin to leak. Okay, so this finally results in proteinuria, right? So whenever there is a nephron loss, there is a progressive decline in the GFR. To maintain the GFR, initially there is intraglomerular hypertension. This intraglomerular hypertension is okay in the initial stages, but in the later stages, what happens is that it results in scarring of the kidneys and glomerulosclerosis, and there can be effacement of the podocytes and lot of protein leak everywhere. So this in turn leads to progressive decline in GFR and results in a chronic kidney disease. Alright? So what happens is that over the course of time, there can also be some immunological activation of transforming growth factor beta. So this is basically responsible for the hallmark feature which we find in the biopsy of chronic kidney disease, which is called as IFTA, which is interstitial fibrosis, right? Transforming growth factor beta is responsible for interstitial fibrosis and tubular atrophy, right? So the hallmark feature that we find is your interstitial fibrosis, tubular atrophy or IFTA. So as the percentage of IFTA increases, that means that the CKD is worsening. Alright. So I hope you have understood till here. We have understood what is CKD. We have looked at what are the most common causes and etiologies worldwide. We have looked at what are the risk factors for CKD and the pathophysiology of chronic kidney disease. Now let us understand what are the hallmarks of CKD. So what are the basic clinical features which help you understand that this patient is CKD and not AKI? So albuminuria, right? So the albuminuria excretion is more than 30 milligrams in 24 hours. Generally, when we look at the filtration barrier, it is negatively charged. Albumin is also negatively charged and it does not allow any amount of albumin to get excreted in the urine, right? So whenever there is a CKD, the podocytes are damaged, the glomerulus is damaged and there will be albuminuria. Another very important for evidence of CKD is whenever you do an ultrasound, there is loss of corticomedullary differentiation. There is loss of corticomedullary differentiation and you have shrunken kidneys. The kidneys are much smaller in size. Okay. So there are certain exceptions to the rule. HIV, diabetes and amyloidosis. HIV, diabetes and amyloidosis are basically those disorders where you do not have shrunken kidneys but you can still have CKD. So in those cases, how will you identify CKD? You will have proteinuria, correct? Okay. Then presence of electrolyte abnormalities, right? They can have persistent hyperkalemia. There has been a progressive decline in the GFR which has been lasting for more than 3 months And you can have shrunken kidneys, albuminuria, and electrolyte imbalance. Apart from that, certain corroborative evidence including the presence of anemia or bone disease. Why does anemia happen? Why does bone disease happen? We will be looking at. Okay, then there can be accumulation of nitrogenous products as well, which results in uremia. But this is not considered to be a hallmark because uremia can happen even in acute kidney injury. So the hallmark features are these. Okay, now let us understand the staging of CKD. Okay, so this is your KDIGO 2012 staging of CKD. So what are the two parameters that they look at? They basically look at albuminuria and they look at the GFR. So they look at the GFR and they look at the albuminuria. So GFR is determined as in these stages. So G1 is your normal or high where the GFR is more than 90. G2 is your 60 to 89 GFR. G3A is 45 to 59. G3B is 30 to 44. And G4 and G5 are your end-stage renal disease where the GFR is 15 to 30 or less than 15. Then persistent albuminuria A1 where normal or mildly increased less than 30 mg per gram. Then A2 stage is 30 to 300 mg per gram, which is your albumin creatinine ratio. Okay. And A3 is where the albuminuria ACR is more than 300 mg per gram. Okay. So if you have asked to stage the CKD, you look at the creatinine, you look at the GFR, you can get the estimated GFR using the creatinine, right? There are certain equations for that, which is the one which we are using now is your MDRD equation. Okay, so we are not looking at MDRD equation in details today. The MDRD equation will be available as a calculator as well. So from the creatinine, you get the estimated GFR and you look for the albuminuria and you stage the CKD. So based on this GFR and proteinuria, this is how you stage your CKD. Okay. Now, let us understand the myriad clinical manifestations of chronic kidney disease. Right. So we have already seen that chronic kidney disease has certain hallmark features. What are the various types of clinical manifestations which are associated with chronic kidney disease? So one, it can have fluid and electrolyte imbalances. You have fluid and electrolyte imbalances because we know that the tubules play a very important role in electrolyte balance and water reabsorption is also very, very important. So if the kidney is not functioning properly, you will have a lot of water retention. Okay. Then bone mineral disease. So calcium and phosphorus metabolism is very important in the maintenance of your bone. Correct? So if the kidney is not functioning properly, you can have a varied types of bone and mineral diseases. Then you can have various endocrine manifestations, you can have various cardiovascular problems, you have neuromuscular problems, dermatologic and hematologic problems as well. So we'll be looking at each of these domains separately. So let us understand the fluid and electrolyte imbalances which can be seen associated with chronic kidney disease. So once the kidney is not functioning properly, we know that the kidney is basic function is to help in the excretion of urea and other metabolites along with water, right? So the kidney is not functioning properly, there will be ECF expansion, right? So you will have pedal edema, you will have elevated JBP, you will have facial puffiness. Facial puffiness is one of the earliest signs of chronic kidney disease. And you can have bivasal crepitations also in the later stages. Why does this happen? Because as the GFR declines, the urine output declines. As the urine output declines, then the water cannot be excreted and there is accumulation of water and expansion of the extracellular fluid. Potassium hemostasis. Very, very important. We have seen in the chapter of hyperkalemia as well that CKD is one of the most important causes of hyperkalemia. In fact, if there is refractory hyperkalemia, then it is an indication for hemodialysis. So refractory hyperkalemia is in fact an indication for hemodialysis. So all CKD patients have a high propensity to hyperkalemia. That is the reason why you give them a low potassium diet. Low potassium diet becomes very important in CKD, and also avoid drugs which can worsen the renal failure or worsen the hyperkalemia. Then metabolic acidosis. You will be learning in the chapter on acid-base balance that the hydrogen ion excretion is a very important role of the kidneys, right? So the hydrogen ions are excreted, they are neutralized in the form of ammonium and excreted from the kidneys so that they help in maintaining the neutral pH in the blood. So whenever there is renal failure, there is accumulation of H plus ions, and the H plus ions, as they accumulate, it results in acidosis. Right? So why is this? Acidosis can worsen the hyperkalemia, and hyperkalemia can cause even cardiac arrest. So this becomes a vicious cycle. So one of the most important functions of the kidney to maintain your acid-base status, to maintain your fluid and electrolyte balance, is lost with chronic kidney disease. Alright? So till here clear. Now let us understand the different hematologic manifestations of CKD. So what are the various hematologic manifestations of CKD? Most importantly, the first point that you have to remember is that this is associated with anemia. Anemia basically means that a low hemoglobin. So hemoglobin less than 13.5 in females and less than 14.5 in males is anemia. Okay. So what are the causes for anemia in a patient of chronic kidney disease? 1. There can be relative deficiency of erythropoietin. We know that erythropoietin is basically a hormone which is produced from the kidney, and erythropoietin basically stimulates the bone marrow to produce RBCs, right? So erythropoietin is a stimulation for hematopoiesis, right? So whenever there is a kidney failure, erythropoietin is not produced properly and you can have anemia. Apart from that, CKD is a pro-inflammatory state. CKD is a pro-inflammatory state and it is associated with decreased RBC survival. So CKD is a pro-inflammatory state and it is associated with decreased RBC survival. So this itself can cause anemia. Many of the patients can have concomitant iron or B12 deficiency. Many of the patients can have concomitant iron or B12 deficiency because they have a very poor intake, and this itself can contribute to the anemia of CKD. Then CKD is a pro-inflammatory state. Apart from that, CKD can be associated with uremia. CKD can be associated with increased levels of parathormone. Why increased levels of parathormone? We will be seeing. So both of these can in turn cause bone marrow suppression. Both of these can in turn cause bone marrow suppression and result in anemia. Then there can be poor dietary absorption, or there can be loss of blood from somewhere, because CKD also has a pro-bleeding state, right? It can contribute to bleeding diastasis. So there can be loss of blood from somewhere as well. And most importantly, CKD is associated with anemia of chronic disease. Anemia of chronic disease or anemia of inflammation, because CKD is a pro-inflammatory state. So these are the various reasons why you can have anemia in a CKD patient, right? So let us understand what is this anemia of chronic kidney disease. So in anemia of chronic kidney disease, what happens? The serum iron is low. The serum iron is decreased. The percentage saturation of transferrin, this is also low. What happens to the TIBC, the total ion binding capacity? This is also decreased. And what happens to the serum ferritin? The serum ferritin is increased, right? Right. So what is the anemia panel in anemia of CKD? You have low iron, you have low TIBC, you will have low transferrin saturation, and the serum ferritin is elevated. Now, how will you identify iron deficiency anemia in the presence of CKD? How will you identify iron deficiency anemia in a CKD patient? Like I said in the previous slide, iron deficiency anemia itself can be one of the causes of anemia in chronic kidney disease. So if the serum ferritin is less than 500, transferrin saturation is less than 30%, that means that there is a concomitant iron deficiency anemia. Okay, so if the serum ferritin is less than 500 and the T-sat is less than 30, that means that there is a concomitant iron deficiency anemia. Now let us understand the management of anemia of CKD. Let us understand the management of anemia of CKD. So first things first, always correct the iron deficiency anemia. Will you give oral correction? No, there is no role of oral correction in CKD because Iron is very poorly absorbed in CKD patients. So there is no role of oral correction. So what are you supposed to give then? You are going to give it IV correction. You are going to give IV correction, right? So you give IV iron. What is the drug which we are using now? We are using ferric carboxy maltose. So what are we using now? We are using ferric carboxy maltose, which is given in an IV form, and you improve the iron stores, get the TSAT more than 30% and see if there was iron deficiency anemia which was worsening this anemia of CKD. Okay. When do you give erythropoietin? When do you give erythropoietin? So, if the hemoglobin continues to be less than 10, you have seen that there is no bleeding, there is no loss of blood from anywhere, they do not have iron deficiency, they do not have B12 deficiency, you've corrected all the nutritional deficiencies. In spite of that, the patient continues to have a hemoglobin less than 10, then you have to correct it with erythropoietin supplementation. You have to correct it with erythropoietin supplementation. So the first generation erythropoietin which is used is your epoietin alpha. Second generation includes your darbepoietin. Okay. So this darbepoietin is given as a weekly dose. Okay, and darbepoietin is considered to be more effective than your first generation erythropoietin. Okay, but always remember that there are certain side effects to use of erythropoietin therapy. Most importantly, erythropoietin therapy predisposes to the formation of thrombosis. It predisposes to the formation of clots. So you can have MI, you can have stroke. That is the reason why in patients with high risk of these, you can avoid erythropoietin supplementation. What is a contraindication? So active malignancy is a contraindication for erythropoietin therapy. So sometimes you can have a poor response. You can have a poor response to erythropoietin as well. So when you have a poor response to erythropoietin, what are you going to think of? What are you going to think of? You will definitely have to see if the patient has a iron deficiency anemia or a B12 deficiency anemia, right? So you definitely have to see if the patient has an iron deficiency anemia or a B12 deficiency anemia. Apart from that, is there any other reason? Is he bleeding from somewhere? Sometimes there can be antibodies which are produced to this peripheral erythropoietin. Sometimes there can be antibodies which are produced against this peripheral erythropoietin therapy. Right? In those cases, we have to resort to certain other ways of treating your anemia of chronic kidney disease. Alright, what are the newer drugs that are used? The newer drugs that are used are your HIF stimulators. HIF stimulator. HIF stands for hypoxia inducible factor. HIF stands for hypoxia inducible factor. So, HIF stimulators are used and the newer drug is your roxadustat. So, the newer drug which is used is your roxadustat. Okay, fine. So, this is about your anemia of chronic kidney disease. So, we have looked at one very important manifestation which is your anemia of chronic kidney disease. Let us look at the next important hematological manifestation. CKD is associated with abnormal hemostasis. CKD is associated with abnormal hemostasis. They can have an inherent platelet dysfunction which can result in bleeding, especially uremia can result in platelet dysfunction. Functional ability of the platelets is lost and they can have bleeding. Apart from that, CKD can also have a risk of thrombosis also. That is the paradox. Why? Because the clotting factors are also synthesized in excess. Right? The clotting factors also can be synthesized in excess from the liver and it can predispose to the formation of thrombosis. Okay? So that is about your hematologic manifestations of CKD. Right? So that is about your hematological manifestations of CKD. Now we will move on to CKD MBD or your CKD mineral bone disease. Okay, so that's about your CKD mineral bone disease. So what is this CKD mineral bone disease? It basically refers to the abnormalities in calcium or phosphorus metabolism resulting in disorders of bone turnover or vascular or soft tissue calcification. So there are three basic components which are associated with CKD MBD. It can be problems with the bone, it can be problems with the vasculature, it can be problems with the soft tissue. So there are problems with calcium and phosphorus metabolism such that you can have soft tissue or vascular calcification and you can have bone abnormalities. So that is your CKD MBD. So CKD MBD is classified into two types. We have the high bone turnover disease and the low bone turnover disease. So there are two types, high bone turnover disease and your low bone turnover disease. So the most important ion that you have to remember, which is your villain of your high bone turnover disease, is this phosphate ion, right? So is this phosphorus, right? So now what happens as the GFR falls? Let us understand the pathophysiology of this high bone turnover disease. So when the GFR is more than 20, what happens is that there is some amount of vitamin D deficiency, because we know that whenever you look at the metabolism of vitamin D, the formation of cholecalciferol and is by the action of 1-alpha hydroxylase, which is there in the kidney. So when the kidney is affected, this action is not there. So there is no formation of cholecalciferol because 1-alpha hydroxylase action is lacking. So you can have vitamin D deficiency. Activated vitamin D is not formed, right? So activated vitamin D is not formed. Now because of this vitamin D deficiency, what happens is that the calcium is also low, right? So the calcium is low, the phosphorus is also low. The PTH usually remains normal or it slightly begins to increase. Or it remains normal, okay? But as the GFR drops to less than 20, you will continue to have vitamin D deficiency. But what happens is that there is a problem with this molecule which is called FGF23. So what is this FGF23? FGF23 is fibroblast growth factor 23. So what is the function of this FGF23? It has phosphaturic action. It causes excretion of phosphate ions. So if this FGF23 action itself is not there because the GFR is declining at GFR is less than 23, the FGF is unable to act. If any FGF is unable to act, the phosphate begins to rise. Okay. Now the phosphate begins to rise. What gets stimulated? The parathormone gets stimulated. Because what is the main function of parathormone? It is responsible for the reabsorption of calcium and excretion of phosphorus. So as the phosphate begins to accumulate, it causes stimulation of the parathormone so that the parathormone can start excreting the phosphorus. Okay. Now once the parathormone gets stimulated, it causes hyperkalemia because parathormone causes reabsorption of calcium. Okay. So can you understand that as the phosphate begins to rise, there is secondary hyperparathyroidism. Which further causes further stimulation of this calcium. And you can have hyperkalemia. In worse stages, now as the GFR falls even further, the PTH can start rising independent of the calcium phosphorus levels. It is independent of the calcium phosphorus levels, and this is what we call as tertiary hyperparathyroidism, because this prolonged secondary hyperparathyroidism can cause the parathyroid glands to become autonomous and they autonomously start secreting PTH, and you can have tertiary hyperparathyroidism as well. Okay, fine. So that is the reason why this molecule phosphate and this molecule PTH becomes very, very important. And you keep a target of PTH of up to 2 times only. Because if the PTH begins to go up beyond that, then you can have a high bone turnover disease. So levels of up to 300 are permissible. Okay. Fine. So till here we have understood that GFR is less than 20, FGF23 action is not there, so phosphate begins to accumulate, it causes stimulation of parathormone and it causes hyperkalemia. So what happens as a result of this? If the PTH is high, so what? So PTH causes resorption of the bones. Right? It causes resorption of the bones, and this is what we call as osteitis fibrosa cystica. Right? So high bone turnover disease is characterized by osteitis fibrosa cystica, where you can have these kind of resorptions in the phalanges or in resorption in the other parts of the bones, and this is also known as your brown tumors. This is also called as your brown tumors, which are cystic spaces in the bones, and it can result in fractures. Apart from this excess amount of calcium, can also cause vascular calcification, right? So it can also cause vascular calcification. So this is the reason why this PTH and higher phosphate levels are considered to be a bane in this high bone turnover disease, correct? So this is about your high bone turnover disease. Now, in certain people, you can have a low bone turnover disease. So what happens here in patients who are on calcium and vitamin D supplements, or a calcium-rich hemodialysis? They are undergoing a calcium-rich hemodialysis. So in these CKD patients, what happens to the PTH? The PTH remains suppressed. Below very, very low levels. Then what happens here? Then this results in a adynamic bone disease. And this adynamic bone disease is going to predispose to fractures. It predisposes to fractures. Okay, so these are the two types you can have. You can have a high bone turnover disease and you can have a adynamic bone disease. Now these patients, what is the profile like? The PTH is low, calcium is high. So what happens is that this calcium can go and deposit in the soft tissue. And this is what we call as tumoral calcinosis. Where you have tumor-like calcium deposits in the soft tissue as well. And it can cause vascular calcifications also. Okay. So this is about the two types of bone disease we have learned. We have learned high bone turnover disease and we have learned low bone turnover disease. Now, what is this image? Okay. In certain patients, if you have started the patient like a CKD with atrial fibrillation and you have started the patient on warfarin, if they have a low bone turnover disease, this high calcium along with the warfarin can cause a devastating arteriolopathy. What is the meaning of that? It causes an arteriolopathy. Can you cut that last line? It causes arteriolopathy, where it causes widespread necrosis of the skin. Right? It causes widespread necrosis of the skin because there is an arteriolopathy, there is a block in the arteries, most commonly precipitated by the use of anticoagulants like warfarin, where it starts as a small painless nodule and then results in widespread skin necrosis, and this condition is what we call as calciphylaxis. Okay, so this is a devastating condition where you can have widespread skin necrosis in patients of CKD with hyperkalemia and who have been initiated on drugs such as warfarin. Okay, fine. So that is about your two types of high bone turnover disease and your low bone turnover disease. Now let us understand what will be the treatment for high bone turnover disease. In high bone turnover disease, what is high? PTH is high, phosphate is high. So you will have to give PTH inhibitors or PTH binders, and you will have to give phosphate binders like sevelamer. Whereas in low bone turnover disease, what is high? Calcium. So you will have to stop your calcium vitamin D supplements. Okay, fine. What are the indications of parathyroidectomy in CKD? So what are the indications of parathyroidectomy in CKD? So I told you that in high bone turnover disease, the parathyroid gland can become autonomous and start secreting parathyroid, right? So that becomes a devastating complication. So in such cases of tertiary hyperparathyroidism, you may have to remove the parathyroid gland. Then in cases of resistant pruritus, in cases of calciphylaxis, all of these are indications of parathyroidectomy in severe hypercalcemia in CKD. In severe hypercalcemia or severe hyperparathyroidism, another drug which is used is your cinacalcet, which is your parathyroid, which inhibits your parathyroid hormone. So that is about your CKD MBD. Okay, clear? What all have we learned till now? We have learned about anemia of CKD. We have learnt about CKD MBD. We have learnt about the mechanism of high bone turnover and low bone turnover diseases. Fine? So, this is again reiterating your treatment for high bone turnover disease. You mainly give PTH inhibitor or phosphate binders. In adynamic bone disease, you stop your calcium and vitamin D. What are the newer phosphate binder drugs which are used? We have tinapranor and sucropheric oxyhydroxide. Okay. Tinapranor is a sodium phosphate exchanger. It is a sodium phosphate exchanger, and sucropheric oxyhydroxide is basically given orally and helps in absorption of phosphorus. Okay, so this helps in decreasing the hyperphosphatemia which you can see in CKD. Now let us move on to the cardiovascular abnormalities which can be seen in chronic kidney disease. So let us understand the cardiovascular abnormalities which are seen in CKD. So hypertension. So one of the most important thing is that hypertension can predispose to CKD, and CKD can result in refractory hypertension or difficult to control hypertension. So the target BP should be less than 130 by 80 mmHg. Right? Target BP should be less than 130 by 80 millimeters of mercury. Then vascular disease. We know that atherosclerosis can be a common comorbidity associated with CKD. Apart from that, CKD can have widespread calcification which causes stiffening of the arteries, right? So it causes severe vascular disease which can worsen the hypertension, which can worsen the cardiovascular outcomes. Then CKD in itself can predispose to heart failure because PTH, uremia, all of this can cause heart failure. It can cause left ventricular hypertrophy. It can cause left ventricular hypertrophy which causes a form of heart failure with preserved ejection fraction. Also, in our chapter on AKI, we have learnt about your cardiorenal syndromes where you have your type 3 and type 4 which is your chronic renocardiac syndrome. So we know that CKD can predispose to heart failure. Okay. Then pericardial diseases. Uremia can cause pericarditis, and it can cause pericarditis with pericardial effusions. Okay, these pericardial effusions need not always result in a tamponade. So whenever there is a uremic pericarditis, it is an indication for dialysis. It is an indication for urgent hemodialysis. So we have already learned what are the indications too. One indication is your refractory hyperkalemia, other one is your uremic pericarditis. Okay, fine. Now, let us look at the neuromuscular manifestations of CKD. The neuromuscular manifestations include uremia can cause lot of confusion, uremic encephalopathy. Then, you find a peripheral neuropathy. What is this type of peripheral neuropathy? This is a distal symmetric sensory motor neuropathy. Distal symmetric sensory motor neuropathy, mainly because there are a lot of toxins which are produced which can cause nerve damage. Okay. Then restless leg syndrome. Restless leg syndrome is another important association of the neuromuscular manifestations of CKD, where in the night they feel that their leg is very restless and they have sleepless nights because of their urge or uncontrollable urge to move their legs. Right? So that's about your neuromuscular manifestations. Let us understand the dermatologic manifestations of CKD. This includes uremic pruritus, right? Refractory pruritus is actually an indication for dialysis. It is an indication for parathyroidectomy also. So you can have uremic pruritus. Then you can have skin lesions such as prurigo nodularis. You can have skin lesions such as prurigo nodularis, which are purple plaques which occur most commonly seen in your shins, which occurs due to chronic uremia. Then dialysis associated amyloidosis. So what happens is that over the course of time, it depends upon the type of dialysis that the patient is on, and it depends upon the flux of the dialysis. That means how many molecules, which is your middle molecular weight substances like beta-2 microglobulin, right? So there are middle molecular weight substances like beta-2 microglobulin which are not effectively filtered out during a dialysis session. So over the course of time, if the beta-2 microglobulin gets accumulated, it results in this condition which is called as dialysis-associated amyloidosis. Okay, this results in a condition which is called as dialysis-associated amyloidosis. Fine. So this is about the various dermatologic manifestations of CKD. So with this, we have come to the end of this chapter on chronic kidney disease. We have learned the definition, the staging, and we have understood various clinical features of chronic kidney disease. In the next chapter, we will be discussing about the treatment of CKD, including dialysis and renal transplant. Thank you.